Fertility treatment is a crucial next step for many trying to have a baby. Joining us now is Dr. Jordan, who helped me accomplish that. Dr. Jordan, thanks for coming.
I really appreciate this opportunity. Thank you for having me today.
So one of the big questions that a lot of people ask is, at what point does somebody need to come to you?
Well, as a fertility specialist, we would like to see patients not after long, prolonged struggles. And for patients that are younger, 35 years of age, we would like to see them after 12 months of unsuccessful conception. After 35, we really would like to see them after 6 months, because time becomes an essence for females who are over 35.
Dr. Jordan, I was about 30 when I went to you and freaking out, thinking that I would never have kids. And we first said, hey, let's prepare my body. Let's get prepared. So what do you tell people to do when it's time to prepare? And I know a lot of people don't probably do this, but how do you get ready to get pregnant, especially when you're having issues with infertility? Exercises, supplements, what do you do?
I think it's a fundamentally great question, because fertility is not just fertility treatment or fertility fix for one factor, particularly for female infertility. Majority what is bank on quality of eggs. So age definitely factor for egg quality. However, what you do on a daily basis, what your nutritional status, what your routines are, do impact egg quality for young patients and patients that are older. So a fundamental preparation for conception is critically look at your lifestyle, look at your nutrition, and maybe consider some supplements. So for example, I really stress for patients consider regular nutritious meals, and ideally consideration for 3 meals, structured breakfast, lunch, and dinner is a very good basis to start preparing for conception, and avoidance of prolonged fastings or very radical dieting. Now, for physical activity, in general rule, to be active, 30 minutes to an hour brisk exercise every day or every other day is sufficient. Obviously depends on general condition of a patient, and avoidance of excessive exercise like muscle building or exercise marathon running. Those may interfere with fertility. And for supplements, more and more evidence suggestive that there's some particular supplements very important in preparation for conception, and one of them is folic acid. We know it's reduced significantly neural tube defects, facial defects, and miscarriage in women, even in young age. We suggest that patients start with 800 micrograms or 1,000 micrograms every day prior to even planning conception, ideally 3 months ahead. Additionally, more and more evidence shown that vitamin D insufficiency or deficiency also impact egg quality or also journey during pregnancy, and deficiency associated with increased blood pressure disorders in pregnancy. And so supplementation with vitamin D is suggestive. I generally suggest 2,000 international units taken daily, again, prior to conception or any fertility evaluation treatment. And finally, there is more emerging evidence that such as factor as CoQ10 becomes very important in egg ability to be fertilized and create an embryo and obviously establish a conception. So this is also part of recommendation prior to fertility treatment to start some CoQ10 supplementation. That's a wonderful question. Thank you.
So much knowledge in that question right there. And you have this confidence when patients come to see you that I'm going to get you pregnant. We're going to figure this out. But sometimes, in my case, I never found out what was wrong, but I can tell you I had 2 children. How I did it was through a steroid at one point, but I don't know if that was what I'd been missing the whole time. But that is something that so many people go through of like, what's wrong with me? And what if we don't figure this out? Does that mean all hope is lost?
This is a very, very interesting question, because it does require a little bit longer answer. So in order to figured out if what factor or factors of infertility. We always do evaluation. And in evaluation, we rule out a major problem such as male factor infertility, ovulatory problem not ability to release an egg, or fallopian tubes, absence of which would be a major preclusion from conception, uterine factor. Those factors we truly can have a tool or evaluation and find if that factor present or not. And majority of couples have multifactorial infertility. For those couples, it's a lot of time a relief to actually know there's a factor, but it's leaving about 15 to 20%, depends on age category, female age category, patients who don't have any problems with tubal factor, male factor, or ovulatory factor, and they are younger than 35, and we call them unexplained infertility. But it does not mean you don't have a problem. You do have a problem, but you may have a very unique problem.
Yeah.
And many times it could be peritoneal factor, which is factor that involves environment when egg released in your pelvis. And a lot of times there's a fluid that might have inflammatory effects and prevents egg and sperm interaction effectively. So that's one. Or there's a subtle problems with fallopian tubes that is not very easy to visualize on traditional testing. So unexplained infertility approach still similar like other factors of infertility, though a unique twist. And a lot of times it's required significant optimization with lifestyle, looking for inflammatory factors, looking for endometriosis that's very commonly associated with unexplained infertility, which is not easily determined and requires surgical evaluation. But unexplained infertility is one of the most perplexing conditions because, again, it doesn't give you an answer. But my approach for it is always, you do have infertility. We don't know the factor, but we have evidence-based approach for treating patients with unexplained infertility that will get you pregnant. And just as you shared great news, you have 2 children, unexplained infertility is treatable infertility like any other ones.
And Dr. Jordon, there are so many letters of the alphabet. There's IVF, there's IUI, vitamin D, A, B, C. You have a process, you do. I remember talking to you, wondering if I would have to do IVF, and you were like, it's very expensive, and a lot of people understand that. So how do you start people? Where do you start them? Where do you go? We have all of these different, medications you can take. Then we have, the letters. Where do you start people so that we can sort of rule out the process and get to the next step?
Renetta, as always, you have such a fundamental, great question. So as we alluded a little bit earlier, start with lifestyle optimization, looking for potential optimization for fertility performance. It's a first step. Seeing us in an infertility clinic and having a very thorough consultation, looking for other identifiable factors of infertility, then have targeted evaluation. So evaluation of infertility is very important. That is going to point you towards the potential identifiable cause or ending up having unexplained infertility diagnosis later. So after evaluation, usually it's so fundamental, sit down and look at all factors. What we could optimize, what could be done with findings, let's say tubal factor or male factor, and then to see where potentially prognosis of treatment that proposed to a patient may lead us. Now, treatment of infertility may range from very simple as lifestyle optimization and patient get pregnant, or getting pregnant just during evaluation. In fact, 15 to 20% of patients younger than 35 may get pregnant during that process.
Oh, that's awesome.
Leaving about 40 to 60% of patients needing intermediate type of treatment, sometimes intrauterine insemination,
That's
ovulation
IUI.
induction. This isn't, yes, IUI. And ovulation induction for patients who are not ovulating and so forth. And in combination, that a great number to get pregnant with simple treatments. Again, if there's no reasons to proceed for advanced treatments. However, about 20 to 25% of patients that in generally seen in our clinic would proceed eventually to assisted reproductive technologies such as in vitro fertilization. And in vitro fertilization has its own different procedures, such sometimes we test embryos before implanting, pre-implantation genetic screening or diagnosis. Sometimes we use gestational carrier if uterine factor is unresolvable or not able to be corrected. Sometimes we use intracytoplasmic sperm injection for very severe male factors. So in vitro fertilization has its own letters and abbreviations and complicated procedures
type of letters of the
for
alphabet there.
every single couple or case that are unique.
But each case is different.
Each case is different, even for IVF. But in general, 20 to 25% of patients will proceed that route. And it is very complex treatments. And treatments required a lot of discipline from patients, for providers, and also entire team that involve embryology, clinical staff. Patient needs to follow instructions very carefully. And as a complexity is, we are designed, our clinic as well as myself, leading a team of providers that are able to get through each step of that complex process with great success. In fact, our IVF pregnancy rate has been incredibly great, and most of our patients conceive from first or second embryo transfer, which is remarkable. And our goal is also to give patients that treatment that they really need and not jump to the most expensive or most elaborate treatment, because most patients don't need it. And so initially when we see patients, that's the message we want to transmit. Thorough evaluation, thorough preparation will lead us to choose the right treatment. Now, sometimes we will have to escalate, start with something simple, but then more evidence surface, maybe some challenges with simple treatment, or simply not able to succeed. And that gives us opportunity to progress to more complex treatment like IVF. But most patients could be helped, and fertility, as difficult it seems at the beginning, is pretty structured and pretty predictable if we have a team, patient, provider, and clinical staff. It's a very successful, most of the time, journey, just like you experienced too.
And it's not just the woman involved; it's the male factor as well. So, what do you tell patients when they come into you and you, as a patient, think I'm the problem, but really you got to look at the male in this too?
Well, this is also a great question, because naturally women will feel that's something wrong with me. This is very natural, because women are designed to have babies. But it's not possible without a male partner for women to have a child. So definitely quality of sperm and quality of the relationship do play the role. And so in the beginning, practically at the first visit, we address male factor as a very important component of successful fertility treatments. And almost from beginning, we check semen parameters and also screen male factor for risk factor that could be optimized his performance, such as minimization of alcohol intake or quitting smoking make a big difference. So some factors we optimize, make sure they don't use any enhancement drugs and so forth. So male component contributes 40% to reproduction, and a lot of time is not just only factor, but it's contributing. So in order to succeed in multifactorial infertility that involves male, it takes a couple to work towards it, but male factor is essential. It takes two to tango.
Yeah, that's true. Dr. Jordon, one of the things that I love about you is that, and I've talked with some of your other patients, you tell your patients, we're going to get you pregnant 6 months, and you're so confident with it. You are very confident, and you know, the results are here.
Right.
But what happens when everything fails? When you've done IUI, you've done IVF, and all that fails, and you feel like, what else? Have you had cases like that where everything fails and you feel like you'll never be a parent?
luckily, those cases are rare, and I remember them, each one of them by heart, and might count on my hand. There are cases where we do have to find alternatives, and it depends on so many factors. And alternatives for parenthood, besides infertility treatments, are ample. Think about adoption. And there are couples who truly, I mean, it comes to my mind, couples there's no sperm, no eggs, and uterus is not possible to work with. And there are also donor gametes available. We can have donor eggs, donor sperm, and even gestational care. So those options there, it's very complex treatments, but in general, at any bed scenario, we're usually able to succeed. And the final, I mean, there are some patients that we would consider adoption would be a great option. It comes to my mind, one of my patients several years ago who had a medical condition and actually was diagnosed during her initial treatment. She had a condition with her aorta. If she gets pregnant, she would have 50% dying with ruptured aorta. So with very careful consideration with cardiology team, we decided what would be another option. And so we looked at all opportunities. They choose adoption. They adopted 2 beautiful children, and I've seen them in community. I've seen them in the playground, and they eternally grateful that we still give them hope and ability to think, if that doesn't work, we're going to go into adoption. They're very happy parents, and for some couples, that's an option. Well, these days we also have centers for embryo adoption. So couples who complete the infertility journey and they have extra embryos, and a lot of time it's faith-based centers. Embryos donated and they use for procreation for other couples. So this is also an option.
Wow, that sounds like fertility freedom, Berkeley.
Absolutely does. And you were talking about just the emotional and mental toll. And sometimes you do have to switch gears and think about what those other options are. And so coming up after the break, we're going to talk to Ruth Yorio about the emotional part of this journey. Dr. Jordon, thank you so much for all of your wisdom that you shared with us, and I hope that you've given many people watching.
Thank you.
My pleasure, and thank you for having me today.